Okay, well, thank you very much, everybody. We're going to get started. My name is Kishore Wasan. I'm at the University of British Columbia, and on behalf of my colleagues at the Neglected Global Diseases Initiative, we want to welcome you to our webinar called Global Health Access and Equity. And the reason why we've decided to put this webinar together is because UBC is celebrating 15 plus years of establishing and implementing our global access principles. And we want to really discuss and get into a bit of a deep dive over the next 2 hours about global health access and equity, with a particular focus on best practices, practical examples of successes, and current barriers and limitations of implementing such principles and policies at universities and around the world. Um, Recently, our colleagues at NGDI have published a very important paper in Frontiers in Pharmacology at the end of the year, in December of 2023, kind of talking about the history of the global health access principles that we have at the University of British Columbia, as well as some of the technologies and standard of care that are part of that program. So it's in Frontiers in Pharmacology. It was published at December in 2023, and you're welcome to go look at that article. The lead author is Dr. Nancy Galini, with Richard Lester, who's our co-director, Bob Hancock, who's the co-founder, Brett Sharp from our University Industrial Liaison Office, and myself. And I think it's actually an important paper because it sets the scene for what we want to talk about today. And the other thing I want to mention is we are looking at doing a face-to-face workshop on this issue, hopefully at the end of August. And some of the folks that are online today, hopefully you might be interested in participating in that face-to-face workshop in Vancouver. So we'll talk about more at that time. So without further ado, why don't we jump right into it? Our first speaker, and yes, Keith, we can certainly send you the link to the article, and I can do that during the presentations. I'll throw it into the chat. So excellent suggestion to Keith from Keith. So our first speaker is actually Dr. Peter Hotez, which most people know online here. Peter is going to talk about global vaccinations and the anti-poverty vaccinations, science versus anti-science, which has been really one of the big issues that he's been discussing and dealing with for a little while. Now, it's interesting what's going on with Peter right now. Peter is walking the walk as much as talking the talk. He is actually in India today, working on implementing, and actually delivering his COVID-19 vaccine. So Peter has sent us 2 videos that he pre-did for us for this presentation. So without further ado, there's an introductory video as well as a video with his actual presentation. And Peter has told me that if there are questions and so on, please let's gather them and we'll send it to him. But Peter is the guy who does those kinds of things. So without further ado, Matt, let's get Peter's videos up and going for our colleagues that are online.
To you today at UBC. I wish I could have been there in person. Vancouver and the University of British Columbia are 2 of my favorite places to go to. I think it's one of the most beautiful campuses I've ever seen, and look forward to returning in person one day. But we'll get a few things done virtually today by talking about our program in neglected disease vaccines. But alongside, have a sobering discussion about the rise of anti-vaccine activism and how that's affecting the future of both vaccine development and delivery. So thank you for this opportunity. Well, thank you so much for the opportunity to present to you. I'm sorry I can't be there in person, which would have been lovely, but I'm going to give a 25-minute overview of what I see happening in the world of new vaccines, including vaccines for neglected diseases, as well as this rising tide of what we call anti-science. The genesis of this was for both. I started developing vaccines for viruses and neglected tropical diseases 40 years ago as an MD PhD student at the Rockefeller University and Weill Cornell Medical College, where the motto of the university was "Science for the Benefit of Humanity," and I still very much believe that, and I saw as one of the highest expressions of science for humanity being the development of new vaccines. Began working on a new vaccine for human hookworm infection as an MD PhD student at Rockefeller and Cornell in Anthony Cerami's lab, and now 40 years later, that's completing clinical trials. And then we pivoted to make a COVID vaccine, reaching 100 million people in low and middle income countries as well. The point is, that was always part of the plan, that I would devote my life to making new vaccines for global health. The unplanned part was having 4 adult kids, including Rachel, who has autism and intellectual disabilities, and wound up writing the book "Vaccines Did Not Cause Rachel's Autism," because that was the original assertion. And unfortunately, that made me public enemy number 1 or 2 with anti-vaccine groups, but it also gave me a front row seat to what the anti-vaccine movement is all about. So today we're going to talk about both the promise of new vaccines for viruses and neglected tropical diseases, but also how we manage this rising tide of anti-vaccine activism. And now with a new book called "The Deadly Rise of Anti-Science." I'm based at Baylor College of Medicine and Texas Children's Hospital, where I'm the dean of our National School of Tropical Medicine, but also co-head this interesting Texas Children's Hospital Center for Vaccine Development, a group of about 20 scientists, co-headed by myself and my science partner for the last 20 plus years, Dr. Mary Elena Patazzi, and we're making new vaccines for schistosomiasis and hookworm and Chagas disease and leishmaniasis. And then around 12, 13 years ago, we started making coronavirus vaccines because they were orphaned as well. Vaccines for severe acute respiratory syndrome, SARS, as well as Middle Eastern respiratory syndrome, MERS, and then ultimately COVID-19. And we do cutting edge technologies when possible for mRNA and particle vaccines, but we also do this. We also partner with vaccine producers across the world, including low and middle income countries in Asia, Africa, and Latin America, who band together and call themselves the Developing Country Vaccine Manufacturers Network. There's around 40 of them, including the ones on the left, that make their own recombinant protein hepatitis B vaccine. This is done through microbial fermentation in yeast, and it's to make recombinant protein vaccines. It's used to make hepatitis B vaccine. The technology's been around about 3 decades. It's very safe, inexpensive, easy to scale up, and simple refrigeration. So it checks a lot of the boxes for global health vaccines. So whenever possible, we try to use this as making our prototype vaccines before we transfer them to the vaccine producer in low and middle income countries. And we've been doing this now for 2 vaccines for neglected tropical diseases, parasitic helminth infections, vaccines for human hookworm infection and schistosomiasis, and the 2 often are co-endemic with each other, as well as co-endemic for malaria. So we think there may be an opportunity to pair those vaccines with some of the new malaria vaccines that have just been licensed or introduced, such as the RTS malaria vaccine and the R21 matrix M malaria vaccine. And here's the other reason I wanted to show this slide is to show you the map where these diseases occur: hookworm and schistosomiasis on the African continent, Southeast Asia, and Latin America. And the point is that one of the problems that we face is not only the difficulty with the scientific hurdles in terms of the targets, but also the coming up with a sustainable finance mechanism. Because imagine if you're the chief executive officer of a biotech or a big pharma company, this is probably not the map you'd want in your business plan, because your financial returns in North America, Europe, and Japan. And so, what is the finance model for this? And the answer is we don't really know. We've had a lot of success, with access for our low-cost recombinant protein COVID vaccines, but of course, there was a purchaser there, the Indian government, the Indonesian government. We don't have that right now for our hookworm and schistosomiasis vaccine. So we not only need innovation in terms of the science, but innovation in the business and legal framework. Our human hookworm vaccine takes advantage of the pathway for hemoglobin digestion for hookworms. So there's a hookworm there on the left, on the lower left, and it feeds on blood. It breaks up the red blood cells and then starts degrading hemoglobin through a series of stepwise degradation pathways using proteolytic enzymes bound to the brush border membrane of its gut. And then it detoxifies heme through a glutathione transferase, which has minimal peroxidase function, but is a special cavity for binding up heme. So animals that feed on blood, like malaria parasites, don't like heme. So they use things like a glutathione transferase, or they polymerize it in inert pigment. In the case of malaria, hemozoin, and for hookworms, it's primarily that GST pathway. And this is what the X-ray crystal structure of our vaccine looks like. It was solved by Toyina Sojo in our group, and it has that very large pocket. It belongs to what's called a NU class of glutathione transferase, adapted for blood feeding and heme binding and detoxification. And it's a very powerful vaccine in the lab. And we're seeing very high levels of protection in a human challenge model that was developed by my colleagues David Demert, Jeff Bethany, and Alyssa Malkin at George Washington University, and provided proof of concept that this vaccine works as a protective vaccine, more than 90% protection, which we're hoping to publish soon. So this is very exciting. But again, what's going to be the sustainable finance model for that is something that we're currently struggling with. For COVID-19, it was a little more straightforward, although that had its own challenges as well. This is what the world looked like in the middle of 2021. The bubble map is showing where people are not getting their COVID vaccines on the African continent, South Asia, India, Pakistan, and Indonesia. And that happened in part because of a science policy failure. There was such an exclusive focus on speed and innovation in cutting edge technologies like mRNA and particle vaccines. And they were very interesting vaccines, but as any engineer will tell you, when you're focusing on a brand new technology, there's a learning curve before you go from 0 to the 100 million doses that are required. And so we thought that we would come in with our recombinant protein vaccine because we can plug and play directly with the vaccine producers in low and middle income countries. So we transferred our technology, minimizing strings attached, to several countries. India got the furthest. They wound up immunizing 100 million doses of our vaccine technology, which was produced locally in Hyderabad by Biological E, one of their big vaccine producers. That's why it's called Corbevax. And it has been quite a success story from that front, providing proof of concept that you don't have to be a big pharma company to still do big things. And not to demonize the pharma companies either, but we provide an alternative pathway. So this was what life looked like in the early part of the pandemic, sending the production cell bank by World Courier or other mechanisms to these countries that had a proven capacity for scaling up to make vaccines. And we did this with India, that wound up producing Corbevax, Indonesia, that produced Indavac, Bangladesh, which also did a good job, but they never actually produced a product, and also doing this with Botswana in southern Africa. And then we transfer the ownership, so we don't try to hang on to the intellectual property. We actually provide it, and then the host country, in this case for Biological E, India, then works out with the vaccine producer the data sharing plan, how to do the clinical trials. We don't try to micromanage that, how to work with the World Health Organization. And these are the papers on the phase 1, phase 2, and ultimately phase 3 clinical trials that were done, and showing that the level of virus neutralizing antibody was right up there with with the mRNA vaccines and better than the adenovirus and some of the inactivated virus vaccines. So, and it was highly protective in non-human primates. We did that with the Emory University Non-Human Primates Center, and then step-down studies in kids. And by 2 years ago, around this time, 75 million kids got this as their primary immunization, and altogether about 100 million doses administered in India. So that was very gratifying. And Indonesia, they made a similar vaccine, which they called Indovac, and this is made by their local vaccine producer known as Biopharma. And what was also interesting about that is they could come into our lab and we could confirm with them that all of our reagents come from non-animal, non-human sources, no animal cells, human cells. So in a sense, a vegetarian or vegan vaccine, and they were able to work with their clergy to get us certified as halal. So this became one of the first halal COVID vaccines. So it's kind of interesting to see what happens as you go to scale up. And now we're making the XBB booster version of Corbevax, and hopefully that will be ready very soon, a low-cost booster version. So these vaccines are costing around $3 a dose. Again, really checking a lot of the boxes for global health. Now to switch gears a little bit, we're starting to think about what does the world look like as we get on the other side of COVID. Not that we're there yet, but we're rapidly making progress, and the World Health Organization has put together their immunization agenda 2030 that they're also calling the big catch up on the lower right there. And what that means is because of the social disruption from COVID 19, they did lose some ground, and there was a decline in the number of kids getting their immunizations for measles, pertussis, polio, etc. The number that of the decline has been modest, from 86% of the world to around 80%. I mean, that sounds like a big drop, but it's the first time it's gone in the wrong direction. But there's another concern that it's not only the social disruption and supply chain management, but something else is going on, and that we're not bouncing back to baseline because of rising anti-vaccine activism. And so these are some numbers here from WHO, where the global coverage in the orange dropped from 86% to 81%. 2021, the number of completely unvaccinated children has increased by 5 million since 2019. And as I like to say, that's a picture of me in the monk painting over there, because I'm worried about something else happening. Not only the social disruption, but superimposed on this has been this rising level of anti-vaccine activism. So I want to finish up my remarks today kind of explaining about how I think the anti-vaccine ecosystem has evolved or devolved, because I've had a front row seat to this for the last couple of decades, and take you through version 1.0, 2.0, and 3.0. With version 1.0 was the original claim, the false assertions that vaccines cause autism, and that thread still is around. In fact, it's even getting revved up again with the candidacy of, unfortunately, of one of the presidential candidates, Robert F. Kennedy Jr. But then, about 7, 8, 9 years ago, it took a political turn around this concept of health freedom, medical freedom, and now it's starting to globalize. So let's go through version 1.0, 2.0, and 3.0. Version 1.0 were false claims that vaccines cause autism. And even within that, there's a lot of whatever metaphor you want to use, the American football metaphor, moving goalposts, or playing whack-a-mole, where you would come up with one assertion and then they would move the goalpost or knock one down, another one would pop up. So it started out with a paper published in The Lancet in 1998, falsely claiming that the measles, mumps, rubella vaccine has the ability, it's a live virus vaccine, has the ability to replicate in the colon, and somehow that leads to pervasive developmental disorder or autism. And that was shown not to be true. It was a small study in 12 kids. The paper was retracted by The Lancet. And there were large cohort studies that were conducted after that, showing that kids who got the MMR vaccine were no more likely to acquire autism than kids who didn't. And that should have been the end of it. But then we started getting into this situation where they'd come up with another assertion. So Robert F. Kennedy Jr. in 2005 wrote a paper, article in Rolling Stone magazine, that was also simultaneously published in Salon, that claimed it was the thimerosal preservative, mercury-containing thimerosal preservative, that was debunked in the same way, large cohort studies and also non-human primate studies showing it didn't cause those alleged effects. But then again, they switched up again, said it was spacing vaccines too close together, albumin vaccines, or they claimed it was the HPV vaccine for cervical cancer and other cancers that was causing infertility or autoimmunity or causing chronic illness. So it became a pretty exhausting exercise to debunk it each time, and that's how I got involved. That's my with my youngest daughter Rachel, and wrote the book. Vaccines did not cause Rachel's autism, which does a fair bit of detail explaining the basis of why there's no link between vaccines and autism and the scientific evidence for that, whether it's MMR, thimerosal, or alum, or spacing vaccines. Also, what autism is and how it begins in early fetal brain development through the action of autism genes. There's been about 100 autism genes discovered. We did whole exome genomic sequencing, Rachel and my wife Ann and I, and found one of those genes. It's a neuronal cytoskeleton gene, so a lot of them are involved in neuronal connections. In fact, at the end of last year, in 2023, there was a nice study done by this group at Stanford Medical School with brain organoids showing neurons with those autism genes are migrating differently, right? And so this can explain some of the important differences. So it was important to have that alternative narrative because it's not enough to just tell a parent, well, don't blame the vaccines and then leave it at that. I think that's very unsatisfying. You want to know, okay, if it's okay, doc, if it's not the vaccines, what is it? Now we really, I think, have a strong case to make for that alternative explanation. The problem is, once again, anti-vaccine groups weren't going to take no for an answer. They just had to reinvent themselves. And as I like to say, like many trends that started in California but amplified in Texas. So on the left there, what happened in California by the 2010s, so many kids were not getting their vaccines that, not surprisingly, there was a large measles epidemic in Orange County and up in Marin County. And measles is often the first breakthrough infection you see when you have declines in your vaccination program because measles is so highly transmissible, the reproductive number in the double digits. And the California legislature responded appropriately. They shut down the vaccine exemptions and they said, from now on, you want to send your kids to school, your kids have to be vaccinated. I supported that and had the immediate impact of shutting down further measles and other breakthrough infection outbreaks. But it did have a backlash around this concept of health freedom, medical freedom that took off in my state of Texas, where the anti-vaccine groups started getting PAC money, Political Action Committee money, from the far right and support from organizations like the Texas Freedom Caucus and a lot of the podcasters like Alex Jones waved in under this concept of, hey, you can't tell us what we want to do with our kids. And the consequence of that was a pretty sharp rise in the number of kids not getting their vaccines. 100,000 kids now are not getting their full complement of vaccines, and particularly in around the Austin area. But this doesn't even explain what's going on with the 700,000 plus homeschooled kids we have in Texas. We have no idea the percentage of those. So this started to become a real public health issue with so many kids whose parents were opting them out of getting vaccines. But it kind of went on unabated because of the liberal Texas vaccine exemption policies. And unfortunately, that concept of health freedom, medical freedom, really took off during COVID. And this is a paper I wrote in the Public Library of Science, Global Public Health, called The Great Texas COVID Tragedy. And let me take you through it. What I'm showing you on the x-axis is the date, 2020 and 2021, 2022. And here's the daily deaths on the y-axis. These are the peaks of the original lineage in the summer in Texas in 2020. Here's the alpha wave. Here's in the winter of 2021, the delta wave in the last half of 2021, and the BA1 Omicron wave. And then this big green arrow. And this big green arrow represents the time when vaccines were freely and widely available, probably even a little bit before then. And you can see that in Texas, almost 100,000 Texans died one of the worst affected states. But the great tragedy was in Texas. Almost as many people died after the Green Arrow as before the Green Arrow. That's because so many Texans refused to take a COVID vaccine. So they paid for this with their lives by refusing vaccines that were 90% plus protective against severe illness and death. And this was really tragic because otherwise we could have been about the same number of deaths as say in the nation of Canada. So Canada has a similar population size to Texas, similar economy. In Canada, there were 50,000 deaths, in Texas, 100,000. And the difference was these widespread vaccine refusals during the Delta and BA1 wave. And nationally, I estimate that number about 200,000, mostly in states like Texas, Oklahoma, Arkansas, Louisiana, conservative, what we call red states, red being Republican, blue being Democrat. And here's where it gets hard to talk about because our training is that we don't like to talk about Republicans and Democrats and liberals or conservatives, but that is the reality. And this is a study done by Charles Gaba from ACA Signups, but it's been reproduced by the New York Times, National Public Radio, and Axios. And I'm calling your attention to this. This is that same Delta wave over here nationally. And it's basically, but it's dividing it up by blue and red states, blue being Democrat, red being Republican. And it shows you that the deaths are overwhelmingly occurring in red states, and the redder the county, the lower the immunization rate, the higher the death rate. So much so that David Leonhardt of the New York Times simply just called it red COVID. And, how do we talk about that? How do we have that conversation? Because of our reluctance to go into that political realm. But the reality is, it started out at the CPAC Conference of Conservatives in Dallas in the summer of 2021, as the Delta wave was getting underway, and the rhetoric coming out of the CPAC conference in Dallas was, first they'll vaccinate you, then they'll take away your guns and your Bibles. And over these objections to vaccine mandates, they overreached and basically discredited the effectiveness and safety of vaccines at the same time. And so they brought on all these lead anti-vaccine activists who didn't know what they were talking about. And at the same time, there was a pile-on from the U.S. Congress, members of the Far-Right House Freedom Caucus, like Marjorie Taylor Greene or Lauren Boebert and others, that used a lot of aggressive anti-vaccine rhetoric, comparing, in Marjorie Taylor Greene's case, comparing vaccinator to medical brown shirts, using Holocaust analogies, which is very offensive. And then you had Senator Ron Johnson of Wisconsin, Rand Paul of Kentucky, using a lot of anti-vaccine, anti-science rhetoric, and then amplified nightly by Fox News. And this was documented by two groups, by Media Matters, a watchdog group, as well as a group at ETH Zurich, the Federal University of Science and Technology in Zurich, showing how during that Delta wave in the summer, Tucker Carlson, Laura Ingraham, Sean Hannity every night were falsely discrediting the effectiveness and safety of vaccines. And you had Joe Rogan in the fall of 2021 bringing on all the prominent anti-vaccine activists that were talking about ivermectin and this kind of nonsense. And it was a killer. As I say, 40,000 Texans, 200,000 Americans needlessly died because of what we too often call misinformation or the infodemic, which I don't like those terms because it implies it's just some random junk out there on the internet. This was an organized and predatory campaign. And so how do we talk about this? Not that I deserve the comparison with Galileo, but I'll take it. You get the idea. Now the vaccine scientists are, there's a lot of aggression against them and a lot of threats, unfortunately. And now you're seeing this play out in the House subcommittee, which is run by the GOP, and they're holding these subcommittee hearings where on their official Twitter site, they're even saying we're going to sell popcorn, quote unquote. Meaning that this is all about political theater, and Fox News sound bites, and they're parading prominent American scientists in front of C-SPAN cameras to humiliate them and say it was the vaccines that actually did the killing, which is nonsense, or that the scientists invented the virus, which is equally nonsense. So it's taken this very dark turn. This is the new book that came out last September, The Rise of Anti-Science, that describes it. It's globalizing now. As you know, it's gone up into Canada and now in Europe, and even in low and middle income countries. And finally, on my last slide, just entered into agreement with Public Affairs, which is an imprint of Hachette, and together with Michael Mann, the climate scientist, we're going to write about the similarities between the attacks on climate science with the attacks on biomedical science in the new book, which is called Science Under Siege. So thank you so much for this opportunity, and I appreciate it. I know these are sobering comments, but I hope it stimulates a lot of interesting discussion. So thank you so much.
Well, again, thank you very much, Peter, for presenting that provocative and important insight. Um, as to this audience, what I think of importance is the fact that Peter walks the walk. As I said, he's in New Delhi as we speak, making sure that his COVID vaccine is accessible and on the ground in the developing world. So, this is exciting work that Peter has done, and it sets the scene for the importance of global access principles and equity and how we can translate that. So, in the chat, at the request of several people, we've put our paper in there that, as I said, that Dr. Nancy Galini is our lead author, talking about the history of global access and principles at UBC, and then some examples that we've tried to foster underneath that principle and that program. With that, I'm going to now turn to our next speaker, which will be the Honorable Dr. Keith Martin. Keith is actually a longtime friend and colleague of NGDI, and I met Keith many, many years ago when Keith was a member of Parliament representing ridings in British Columbia. And Keith has been a champion for and really, really helped us get NGDI off the ground in the early days. So Keith is the founding executive director of the Consortium of Universities for Global Health, based in Washington, D.C. And between 1993 and 2011, he served as a member of Parliament in Canada's House of Commons, representing, as I said, a riding in British Columbia. And he held shadow ministerial portfolios in foreign affairs, international development, and health, and served on Canada's parliamentary secretary for defense. Keith has had an outstanding career, and we would spend the next half an hour talking about how great his career is if and not have time for him to talk. But today's talk, Keith is going to talk about the politics, the governance, and implementation pathways to improving health outcomes for all. So without further ado, Dr. Keith Martin. Keith, over to you, sir.
Kish, thank you so much for your very kind and gracious introduction. And I have to tell your audience that of what an incredible leader you have been over the years and a guide to myself personally in Parliament, as well as the Consortium of Universities for Global Health, which I'm the executive director right now. Your enduring champion efforts to be able to improve the health and well-being of people around the world and to address neglected tropical diseases that have such a huge neglected impact on so many people around the world. You are a fighter and a champion of those people and their well-being. And I really admire what you've done, and I'm grateful for everything that you have done to help guide us in our mutual efforts in this regard. So I think that I'm not sure who's going to move the slides for me. I'll see if I can do that. Does that work? Nope.
Actually, yeah, we've given you, Keith, the share screen so you can have control. If you can just put your view in full view, that would be great.
Okay, let me just check where that is.
Yeah. But yeah, you have full control of your own slides. That way you can move them at your pace.
Okay, super. I'm just going to look at where full view is from the beginning. Okay, do you see that?
Yeah, perfect. Thank you.
Got it? Okay, fantastic. We're in business. So this was I think, hopefully a very useful part two after Dr. Hotez's really outstanding presentation. And I think what he may not have fully shared with you, and I know this because we're working with Dr. Hotez and other scientists around the world, is what a terrible, brutal impact that the anti-science movement is having on scientists and on science around, not only in the United States, but around the world. And the tragic loss of that, Peter described, are the thousands of people who lose their lives as a result of the disinformation campaign that is really a manipulation of people's fears and challenges to really advance very specific political gains. And I think of all of us as whether we're physicians or whether we're scientists, I think that obviously runs utterly counter to who we are and what we do for a living. So what I'm going to do is really take a look at looking at some of the reasons why this is happening and deal with some of the foundational issues that are enabling inequities to persist. And I don't know if you're like me, but I'm sure you find this. We have so much incredible knowledge. We're privy to this knowledge as people who work in the space. But at our heart, we often probably scratch our heads and feel pretty frustrated that a lot of this information that we have is not being implemented. So we're going to together, we're going to take a look at why that is so and what we can do to address them. So here's the Sustainable Development Goals. We all know they're excellent goals. If we were able to address part of them or most of them, then we would have a really profound impact upon the inequalities that persist in our country today. But if we ask the question, are we going to meet those goals by 2030? The answer is a flat out no. We're far, far away from that goal. And that's the same fate that happened to the Millennium Development Goals, right? We had those goals were also very good. It was great fanfare when they were introduced, yet we were we had abysmal outcomes with regard to achieving them. The similar fate is now awaiting the SDGs. And if you look at every one of these, I would challenge anybody to say that we do not know how to have a profound impact upon all of these 17 goals. So why is that so? Let's take a look. Well, what goes into health? I think those of us who are physicians, and I think in the global health space, we can be accused of actually having a profound biomedical bent. And that's fair to say. We're trained in the biomedical fields. We come to the space with that knowledge and expertise. But if we stand back and ask the question, what actually has the biggest impact on our health? The answer are other things, right? Do we have education, including right from prenatal care to early childhood education, arguably one of the biggest bang for your buck for health outcomes? Do you have money in your pocket? Do you live in a safe environment? Is your environment healthy or not? Do you have access to proper food? All of these things matter. Part of these things are dependent on ourselves, but a lot of these things are dependent upon decisions that are made politically. Whether you do or don't have these issues is often dependent on the political structures, the choices, and the capacity of governments. Now, governments can't do everything. No one would ever say that. But the primary responsibility of delivering public programs, as our colleague Professor Tim Evans at the McGill University would say, is government. Governments have the most money. They have the political, they're allowed from the public, they're voted in to deliver public programs, and they have the capacity of varying degrees of government to implement them. But sometimes they are, with good outcomes and a reduction in inequities, sometimes they're not. Let's take a look a little bit more deeper. So one of the things that I find that in global health that we tend to ignore are, if you ask the question, what determines whether our healthcare systems are stronger? What determines if we have universal health coverage? What determines if you have access to potable water? What determines if you live in an environment that's healthy or not? What determines if groups within countries are actually deliberately marginalized or attacked, as we're seeing now in certain parts of the world, including where I spend most of my time in the United States, in regard to migrants and refugees. They're used as political scapegoats, and they're used as political scapegoats for political ends. So what determines whether or not we have all of those inputs into the social determinants of health is largely determined by the political determinants of health. And there's one of the key messages I'd like you to remember is when we're all doing our work, is to know that knowledge is not enough. Evidence is not enough. And I think you heard that pretty graphically from Dr. Hotez when he described one of many examples of what happened with the COVID-19 vaccine in Texas. But there's so many other areas. I'm going to give you a few examples in a minute of what can be done or not done. So these political determinants of health are, do you have free elections? Do you have an effective public service? Do we have democracy? And I would share with you that, quite frighteningly, we have 18 years, year in and year out, of a decline in democracy and freedom around the world. And that's pretty frightening. Is there press freedom? There are attacks all over the world against the media. Some are subtle, some are overt in terms of assassinating journalists. And that has a huge impact upon the ability of the public to actually know what's going on. Do you have an independent justice system? One of the favorite things of autocracies to do is to co-opt the justice system so that they can use the justice system, just like they take over the press, to advance their own political goals, often at the expense of certain groups, which actually deepens inequities within countries and between countries. Do you have the rule of law? And are there independent oversight mechanisms? These things we often don't actually deal with in global health, but we fail to deal with them at our peril. Let's take a look at some examples. You all remember the Affordable Care Act when President Obama was in, and essentially the federal government in the United States was going to give money to the states if they accepted it, and that would enable them to provide health care coverage, health insurance, to communities, to individuals who are lower income who never had it before. Sounds like a really good thing, right? And it is a good thing, because access to health insurance, as we know, is really important at reducing inequities in outcome. What happened? Well, most states said yes, but 10 did not. And what is interesting, if you look at the 10 that have not done that, those states are some of the deepest disparities in healthcare in the United States. Tennessee, Arkansas, Mississippi. I have colleagues and friends who work there who write to me periodically and say, Keith, what I'm seeing on the ground is just heartbreaking in terms of the lack of access that populations have, low-income populations have, with deep disparities. They can't access some of the basic public health and primary care needs that they have. They may not have access to potable water, adequate housing, adequate education, all those social determinants of health. And they don't have access to the healthcare coverage because their state made a decision not to accept funds from the federal government, depriving their lowest income communities, those with the worst health outcomes, from accessing the health insurance they need to get their care. That is a political choice, and it's a political choice with deep, profound consequences. Another example, in the state next to Dr. Hotez in Louisiana, there's something called Cancer Alley. And check it out. Years ago, the state of Louisiana decided to allow pollution spewing, carcinogenic spewing industries to set up their industries upstream from communities. Those communities were communities of color and low income. The outcome is that those communities that are already poor with poor health outcomes have much higher cancer rates, low birth weights, preterm children, higher rates of maternal mortality and infant morbidity, and lower lifespans. Lose-lose situations. And part of that was a result of the decision by the Louisiana government to allow those industries to set up shop right above and upstream from low-income communities. On a positive side, on the bottom, the government of Canada, Prime Minister Trudeau, decided, his government, to investing in dental insurance for low-income individuals in Canada. This is a fantastic thing because oral health care, as we know, is often neglected. inaccessible for people who don't have the money, and enabling people to have the oral health care will have a profound impact on their health, particularly for those who are lower income individuals. So that's a positive side of what can be done in governments who choose to make those decisions. You stand back and look internationally, those countries with the lowest human development index, take a look at them. If you look at every one of these countries, what do they have in common? Each one of them has in common very poor or weak or ineffective governments. The governance structures are limited. Many of them are have deeply poor communities and poor health outcomes. The development index is very poor. The other side, of course, is that many of them are actually very rich in terms of natural resources. But those natural resources are not being utilized to invest in the public goods for their people. So the lack of access to having good, strong, effective, accountable governance has a profound impact upon the Human Development Index. The other side we talk about in terms of whatever we're trying to seek in terms of investments in human well-being and health requires money, right? I always have this, we go to meetings all the time, and oftentimes the discussion around financing goes to, okay, what are the foundations paying? What are countries paying in terms of their official development assistance? Official development assistance is around $152 billion a year. But if you ask the question, what does it actually take to achieve those sustainable development goals? Well, the answer is around $1.5 to $3 trillion a year. That's a little obsolete. I think it's higher because of the need to invest in climate change and the biodiversity crisis. But you can see that we're an order of magnitude away in the financial discussions. We're looking at official development assistance as a pathway to funding the sustainable development goals and the capacity governments and countries need to provide for their citizens. And yet the real answer lies in the hemorrhaging of finances and resources from low-income countries. I will say one more thing about this, is that these funds actually are harbored not in those countries, but they're actually harbored in high-income countries, in real estate in the United Kingdom, in the United States, and in Canada. And in fact, a lot of those funds are actually hidden in our own financial systems. So in order to address the corruption issue that's resulting in the hemorrhaging and wholesale theft of the resources from these countries, low-income countries, that belong to their people, we're a big part of the problem. And our failure to address in our involvement in hiding and harboring and allowing stolen funds that are coming from low-income countries in the billions and billions of dollars, well, over $1.5 trillion, is something that we need to fix ourselves and we need to advocate for with our own governments. And so the lack of weak governance and political structures leads to conflict, corruption, and a lack of capacity. And if you look at the most corrupt nations in the world, they're all desperately poor, and many of them are failed states. So the point is that we have to deal with, well, I'll say this one last point on this issue. If you look at the world's least corrupt countries, where governments utilize their money and can utilize their money in an accountable way for their citizens, you can see that all of them have strong and effective governance structures. You look at the most corrupt nations, none of them do. So that's a function of the effectiveness of political structures. So what does that mean? We tend to look at the top of this pyramid. I call this the neglected foundation of development. And we tend to focus, of course, on addressing those sustainable development goals, addressing new medications, new programs, new initiatives, all evidence-based, published in journals. Absolutely essential. But as I've been saying all along, in order to breathe life into those programs, in order to breathe life into ensuring what is discovered is applied to improving the well-being of people and reducing inequities, we have to have effective public institutions, not only in health, which we tend to focus on, but you've got to have an effective Ministry of Finance, right? Because without that, money gets lost, money can be corrupted, money can be used for nefarious means. You need an effective public works department so you can put in the water and sewage and other infrastructures necessary. You need proper education systems, right? That actually invest from preschool all the way through to higher education, the environment departments, and importantly, the Justice Department, because the laws have to be able to be not only on the books, but they have to be applied in an impartial way for the betterment of people so that the public interest is actually guarded. We tend to focus, of course, on this issue of we produce a mountain of knowledge, but we're getting a trickle of implementation, and that's not good enough. We need to breathe life into the incredible knowledge that's being produced by determined, highly intelligent individuals, and we need to find a way of building bridges so that that knowledge that's produced is applied. So if we to use Dr. Hotez's example, so the vaccines that are being produced in this case are being applied, and we don't see the tragic loss of implementing what we already know for the public good. So what can we do to increase our impact? Well, I think most of the individuals here were part of institutions, and I think that domestically, a missing area is forging partnerships with governments at various levels to align our research capacity with public needs. This can be done, in high-income countries, probably more so at the local level, but know that there's research that lower-level governments need to do that they cannot do on their own. They don't have the capacity. Local institutions can forge relationships with them. The other one is, how do we overcome issues with students from low-income families to be able to attend higher education? One of the things we can do is to be able to open the doors and provide some programs for those students to be able to come into universities, meet master's students, PhD students, show them the arc of what's possible so that they can at least imagine what is actually available to them and share that more actively with them. Advocacy. We need to advocate for the programs and initiatives that are necessary to reduce inequities, including we must stop poaching professionals from low-income countries. You can't stop people from going where they want. That's not going to happen. But actively poaching professionals from low-income countries is undermining the ability of those countries to be able to strengthen their own nations. And that completely undermines development objectives countries have. Visa reform to enable individuals from low-income countries to travel to high-income countries to be able, or other countries, to be able to work and collaborate with colleagues. Here's an interesting one. I was at a meeting speaking with the Association of Veterinary Medical Colleges once, giving a plenary, and I was walking through the poster sessions, and at a veterinarian conference, there was a dental student. So I stopped and I asked myself, please, what's a dental student doing at a veterinary science conference? Please tell me about your poster. So what happened is that what they did, and this was in the southern United States, that university went to low-income communities and they brought in the vet students to low-income communities and said to them, do you want us to provide primary care for your pets? And they said, sure, we'd love to do that. So final year vet students provided primary care for the people's pets to be able to, which they would never be able to afford. But they didn't go alone. They also brought in the final year dental students and asked them, you don't have dental care. Would you like final year dental students to provide you with primary dental care? And they said, we would love it. So here you have an example of an academic institution engaging with low-income communities to be able to provide tangible outcomes for their lives, reducing inequities. Now you're only limited by your imagination, right? You could bring social workers, nurses, law students to be able to help low-income communities navigate the issues that they're struggling with. And what an incredible interdisciplinary learning opportunity for the students. And of course, there are umpteen translational research opportunities there too. Again, also we need to reform tenure, because right now the way tenure is structured is that those who want to do this work, those who wish to do this work are not, they do it often off the side of their desk, and they're unable to do it in a way that's that they helps them in terms of their career. So we have to reform tenure to be able to value these actions. Now, internationally, at CUGH, we're working with colleagues at the African Forum for Research and Education and Health and others to be able to work with them as they see fit to strengthen their ability to work with other governments, to build South-South collaborations between academic institutions. These will help to strengthen their own capacities as they see fit. We're also seeking to reform partnerships between high-income institutions and low-income institutions. For a long time, and frankly, even now, much of the relationships between high-income institutions and low-income institutions revolve around benefits that accrue to the high-income institutions. That's completely unacceptable. So there are a number of things we can do in terms of providing training opportunities as those institutions see fit, to enable the host partner to lead research collaborations, to be able to ensure that there's durable benefits for infrastructure and technology in the partnerships that are accrued. All of those things will help to have more equitable partnerships that address local needs. Finally, nothing happens without securing political leadership and commitments. So one of the things that we really encourage people to do is engage governments. You've got to be able to engage governments, learn what their interests are, learn their incentives, and then be able to foster collaborations between them as they see fit. And we created a platform that enables capacity building between institutions. Anybody can use it. It's at the bottom. Please take a look at it. Please share it, because it will enable institutions with institutional needs, training needs, to be able to match those with those that have training capacity, and those that have capacity to share their abilities. So finally, and again, it's a segue from Dr. Hotez's comment, often there are discussions that we shouldn't get involved in politics, but quite frankly, if you're not, you don't need to be partisan, but if you're not involved in politics, we're not going to be able to address the inequities before us. We're not going to be able to address the global challenges we face, and we're not going to be able to implement the knowledge that is produced. So the challenge, the final challenge that I want to posit to all of us is that build those relationships up with political structures. We've got to build that bridge. Without building that bridge, we will not be able to implement what is necessary to improve the health of people and the planet and address the inequities before us. Thanks so much, Dr. Wasson, for this opportunity.
Well, thank you very much, Keith, for an outstanding presentation, and a very important presentation, colleagues, because connecting the governance and the politics is really important, because if you really want to make a transformational change on the ground, you need those sources. So thank you very much, Keith, for an outstanding presentation. We will have a question and answer period at the end where you can put comments in the chat, and we will read some of the questions out from at the end. So please keep that in mind. The other thing is that we will have a survey online where you registered for this webinar, that you can provide us feedback of what did you think of today's presentations, what you thought was positive, what are some of the things that we can engage you with down the road. So next, I'd like to introduce Dr. Marianne Fenerjan. Dr. Fenerjan has worked for over 25 years in the areas of technology development at Harvard, beginning with business development focused on genomics, infectious diseases, and oncology. and her current role, she ensures that the university's technology partnerships comply with the institutional and public policies and leads the efforts of its Office of Technology Development to facilitate locally affordable dissemination of Harvard medical technologies in the developing world. So this is actually a very important area. We have a similar office that's led by Brett Sharp here at UBC. So this is really quite important a discussion to have. And the title of Dr. Fenerjan's presentation is Perspectives on Facilitating Global Access in University Technology Licenses. So Marianne, over to you.
Mute and start video. Okay, can everyone hear me? Can anyone hear me? So thank you very much for your kind invitation, Dr. Wasson, for today's meeting. You and the other organizers.
Marianne?
Yes. Hello? Yes? Can you hear me?
Yes, we can hear you well. Go ahead, please.
Okay, good. Thank you. I do not have slides.
Yeah, I think your network is a little unstable. Let's see
If
we can try again.
Okay, I'm not on Wi-Fi. I'm actually plugged right into Harvard's Ethernet system here. So I don't know. Can you hear me now? I'm gonna actually, okay, excellent, thank you. So again, I'd like to thank today's organizers for their very kind invitation to join this distinguished panel. I'd like to say that the first two talks have left me very inspired and amazed at the excellent work that's being done. Working in a university, we see technologies developed across a very broad spectrum. Some of them have applicability in public health, others don't. We see everything from devices from our engineers to potential drugs from our biomedical researchers. And historically, those inventions have been very early stage, discovery stage. And what that has translated into until recent years has been technology that we've gone around begging to companies. These are early stage things, very little proof of concept, certainly no translational development. And I'm talking, 15 years ago when our colleagues at UBC and those of us out here on the East Coast of the United States started working on these things. Considering issues of global health, considering how we might get university technologies translated to a wider and more in need audience than we might otherwise have done. So at that time, we were looking at technologies that were hard for us to license. We would take the inventions that were reported to us, patent them, these very early stage things, and approach companies, marketing emails and marketing phone calls and say, will you take this weak little kitten that we have, this early stage invention, and feed it with an eyedropper every 4 hours and until it builds up and eventually make it into a drug or a medical device or a diagnostic. And we had at the time little in our own perception and the perception of our investigators, little leverage to get the companies, typically existing, brick and mortar, pharma companies or medical device companies, to do much of anything. The power dynamic was definitely they had the leverage and we were the ones, begging with our weak little technologies. And so the idea that we would be able to impose new restrictions, new strategies into licenses to make them do things, to make them make an eventual drug available in the developing world, in underserved populations, in developed countries. That was something of a pipe dream. We were nervous about it. Some of our investigators were nervous about it. They said, "Oh, they barely want to license our technologies now. My invention might never become a drug if you do that. No one will get the drug." And so that was our and their mindset at the time. So considering ways to increase global access to our medical technologies once someone made them into a practically applicable thing, whether it was a drug or a device. A lot of thought and a lot of hesitance was present. People said, "Oh, if someone tries to do a startup, the investors won't be interested. Once you do that, how will they ever get off the ground?" So we thought, but we also realized that we needed to do things. And in part, I credit our colleagues at UBC who definitely took a leading role in this field. And at Harvard here and at others of our sister institutions, we had a great deal of student activism from our law schools, from our medical schools, a group called UAEM, Universities Allied for Essential Medicines. They lobbied hard, and they made the case that we really needed to do something practical. So through long discussions with them and then long discussions with each other, I know that we at Harvard spent a lot of time talking with our excellent colleague, John Soderstrom, who was then the head of Yale's Technology Development Office, and who had seen firsthand the need to try to make drugs available in the developing world when Yale had a drug called Zerit, which was an AIDS medication that was covered by one and only one patent that did belong to Yale, trying to exact concessions out of their existing licensee to get the drug to places like Africa where AIDS was running rampant. John's perspectives were certainly extremely helpful. Eventually, we came to develop a set of principles and strategies, and I'm going to put a link to that document into the chat if I can. Let's see if I can paste. Okay, and that. And this was the result of about a year's discussion, and it was released in 2009 by a group of universities. The original signatories are there. It was endorsed by the NIH and the CDC here in the US, as well as by the several universities that are listed. And since then was endorsed by, several dozen more. And in it, we lay out a number of ways in which we could avoid, first of all, having our patents stand in the way of global access, and of, for example, structuring our licenses with various forms of reserved rights. For example, to have the right to grant an NGO or a governmental entity the right to engage its own manufacturer to make what we had patented and licensed and distribute it to underserved populations. We were able to tweak some of our march-in provisions. Normally, our licenses might contain something called third-party proposed product. We have a licensee of a technology that has many possible uses, and they're developing one or two. And someone else comes along and says, I want to develop this other application. They could then either, our own licensee could either choose to develop a product based at that and directed at that indication, or instead they could say, no, we're not going to do that. And we could then directly license, or they could sub-license the other company to do that other thing with our licensed technology. We adapted that for global access so that they were required to make the product available in developing countries. But if they weren't going to at a locally affordable price or for free, we could let someone else march in and do that. We could take back a part of their exclusivity to do that. So there are various levers. There were also positive incentives. You know, there's the carrot and there's the stick. The carrot is if you sell to a population in a country with economic stratification, a country like India, for example, where you have a very wealthy class and very disadvantaged people living in the same space. You would get a break on your royalties on the market rate product if you then also distributed on a locally affordable or free basis for humanitarian distribution. So all of these principles are in the statement, and we developed a suite of licensing language, various clauses. We have a little toolkit that we can, you know, plug different terms into different licenses. But the question was, what impact would that have? At the time, people were still saying, you're going to lose licenses, your technologies are going to sit there, no one will, you have no power. And we thought about that, and we started pushing. And in many cases, our researchers who were doing research into these various disease areas and technologies, so that they could, you know, fulfill their mission, our institutional mission, public mission of some of our sponsors, to deliver benefit in the form of better health. We were able to get them to help us lobby in some cases. And some of them, you know, quite honestly, were disenchanted with the way their technologies had been treated by big pharma. You know, somebody would license something in, they'd play with it for a few years, the internal champion would leave the company, and then the company would say, oh, sorry, no one's working on that here anymore. And the license would come back and no product would come with it. So a few things happened sort of in parallel. One is that we began developing technologies to a later stage in-house. Harvard and a lot of other universities now developed with internal funds or gift funds, accelerator or translational funds, so that you could take that weak little kitten that I was talking about, that very early stage technology, and fund some of what would have been early stage commercial development. For example, you have a biologist who's gone out and screened a publicly available chemical library, and they've come up with a few hits against their target, but it's nothing you can use as a drug. So with these internal funds or these gift funds, we might engage a CRO to do some medchem. We have in fact recently established a translator lab within Harvard that will be taking in projects and doing the medchem in-house. You might have a chemist who has some great compounds, but they need animal studies. Again, you put these resources on, you get that proof of concept in animals. Then you bring things to a later stage of development. We also, like a lot of other universities, have fostered interdisciplinary collaborations. We have, for example, here, our Wyss Institute of Biologically Inspired Engineering, where we have engineers, we have biologists, we have chemists, and they're all working together to build something that is well thought through, and commercially ready. At that point, with our technologies de-risked in several ways, we have more leverage when we go out to a company and say, are you interested in licensing this? And in that way, when it comes down to the negotiation, we're confident if they aren't interested, someone else will be. In parallel with that, there's a greater culture of entrepreneurship. It used to be that investigators would say, it's my job to do the research. It's my job to publish the papers. Those commercial things are not something I should be thinking about or my students should be thinking about. Money is dirty. And they have come around in many cases, and we and other institutions, I think all of our peer research institutions at this point, have programs in entrepreneurship for faculty members, for postdocs, for students. There are various technology clubs. There are various fellowships that have been established that sometimes bring individuals in to be trained, sometimes teams. We have, for example, here a health tech fellowship program that brings together interdisciplinary teams. You might have a doctor, an engineer, a business person, teaming up, spending an observation period of 8 or 10 weeks in a hospital that we have an agreement with, just observing and seeing what clinical needs look like. Having training in entrepreneurship, even teaching classes to more junior people and how this works, so that they spend some time then innovating. They have learned how to write a business plan. They have seen up close and personal what goes on in a hospital or a clinic, what the needs are. And they are starting companies to take those innovations that have come through their early observations, their training, their innovation period, and taking those out into the world. This has created an interesting dynamic in two respects. One, as I mentioned, we have now more leverage with better technologies and better trained investigators. And by better trained, I mean trained in translation. What is their role? What is our role in getting their technologies out to the public in a way that will benefit the public? And we also have a great increase in the number of startups that our office licenses technologies to every year. It used to be that if our office did 3 or 4 startups a year, that was good. Then it went to 6 or 7, 10 or 12. In the last few years, we've had a couple of years where we've done more than 20, 24, 27. We're averaging in the low 20s for these past 4 or 5 years. And we expect to do something similar this year. By engaging our faculty in the entrepreneurship process, in showing them that sometimes the best way to get your technology out the door is to be the commercial champion, to be the one that wants to start a company, to assemble a distinguished scientific advisory board of your colleagues around you, all of whom are focused on your vision for your medical technology. That's a very good way to get it commercialized, because you're not just sending a technology into a large company that will toy with it for a few years and then maybe lose interest. You have a company dedicated to that technology. They are starting with something more advanced than we would have started with at one point. They then carry it further through the early preclinical and sometimes early clinical stages. And at that point, when it's that far de-risked, sometimes a larger company will buy them. So they're acquired. And at that point, once, say, Big Pharma has made an investment in buying a startup, which is a lot more expensive for them than taking a license, but at the same time, less expensive and less risky than doing the in-house development and having more failures as they go along. We are in a better position to say, these are the terms. They buy the company, they've got our license. Our license has the global access terms in it. Because it was more advanced in the beginning, the investors did not balk at having global access terms in the license. And it is something that we've seen our companies are succeeding at a greater rate. And all of them have included in their licenses the global access terms that implement the statement of principles and strategies that I sent you the link to. Now, in terms of the real world application of the principles, I will say that because this upswing in licenses that contain those terms, and especially those that have gone into startups, is in the past few years, we do not have situations that have arisen where we have needed to march in. There are not the drugs that are ready yet. And I hope to be able to speak to you 5 years from now and say that, yes, there are drugs, and yes, we are making them available in developing countries and in underserved communities here in the US. Now, one of the areas in which I think we can have impact mostly is through those reserved rights that I mentioned for working with NGOs and governments. And in those cases, whether it will be our original licensees who say, oh, okay, if someone else is going to make them, we'll sell them at those lower prices, or we will cut a deal with WHO or the Gates Foundation and enable them to bulk purchase something at a rate that will allow them to do humanitarian distribution where drugs or devices are needed. That's something that I think is realistic. Again, we'll see in 5 years. But I hope that we can see the fruits of these efforts. I also hope that we can, over time, engage more universities in endorsing these principles and implementing them themselves. I know that Autumn does have its own global access toolkit. One of the issues that came up when we first put these principles out, people raised concerns about antitrust. If all of the universities are asking for the same terms, do we have an antitrust problem? I don't know that we do. And certainly our own toolkit that we developed here at Harvard has been mostly used in-house. Occasionally a colleague will ask, do you have some language for this type of a global access term? And we will share that. But I think by and large, the institutions that endorsed the SPS have developed some of their own terms. Others may be using the Autumn toolkit. And so, there are resources out there, certainly. The other thing is I will share that the SPS, which is our little guidebook for doing global access licensing, it does provide in its own terms that it will be revisited every few years and improved. We tried that, and we did convene a meeting, and many people came, and no new institutions signed, and that was discouraging. Some will use the excuse that they're X type of public university where their mandate from the state has been that they're to engage in economic development, and they don't want anything to impede their state mandated mission. Others may be quietly doing things on their own, but don't want to publicly commit to take a certain approach. we tried in drafting the SPS to be as flexible as possible so that these are principles, these are approaches you might take, but not mandating specific language. Again, it was meant to enable people to implement what they could. I will share with all of you, as I share with colleagues from other universities and research hospitals, Harvard has never lost a deal on account of the inclusion of global access terms. We have never lost a deal, and you will not lose a deal either if you persuade your organization to push to have new drugs, medical devices, diagnostics delivered to populations in need. One of the issues that we first encountered, you can say you cannot use our patent rights to restrict access to a drug that you may develop in a particular country or set of countries. And they'll say, yes, but we have 10 more patents that we have filed ourselves, the company will say. And so this is where the fine points of some of the language come in. If they are not distributing the drug, no reference to our patents, but the licensed product, regardless of how many other patents it's covered by, in certain countries, under certain terms, that is when we can march in. And so it's not just like, you can't use our patent. It's like, you've developed this whole drug. It's covered by whatever suite of patents, one of which happens to be ours. We are going to retain the right to make you distribute that drug. Your other patents are your business, but we are very interested in having this go out to people in need. And you're going to make that happen, or we're going to make that happen under our reserved rights. I do believe that there is benefit to companies in sublicensing their partners of choice before we march in, before we exercise our rights. Again, getting back to some of the countries that Dr. Hotez mentioned as having vaccine manufacturing capability. There's a lot of generic drug manufacturing capability in, say, India, and in other countries as well. And certainly those are countries in which we could license someone under our reserve rights to manufacture and to distribute on a humanitarian basis, whether that's directed by an NGO, whether that's directed by a local government, whether it's directed by a company that we also license under our reserve rights. There are ways of making that happen. And the key is some measure of oversight to make sure that the drugs that are manufactured in that way don't make their way into the general market, aren't exported into, say, major market countries. Those are actually some of the more compelling reasons for our direct licensees to do these things themselves, because they control the flow of materials, they control pricing in the different markets. And as a result, they're able to meet their obligations to us, help us meet our mission-directed goals, and improve health around the world while still maintaining business as usual in major market countries. I'm going to.
So Marianne, we need to kind of wrap up if you,
and that's
if you don't
just
mind.
what I was
Yeah,
about.
thank you.
That's just what I was about. I said I'm gonna wrap right there. So again, thank you so
I
much.
appreciate that. Thank you. Thank you.
Yep.
Okay, thank you. My vote is so thank you, Marianne, very much for your presentation. I am breaking up a little bit, so let me just throw me on video. Hello?
We can hear you.
Hello?
We can hear you.
Can you hear me? Okay, I'm gonna turn off my video because I'm breaking up. But Marianne, thank you so much for an outstanding presentation. I think that you bring up extremely important issues of translation and the importance of being able to get the university to help us move things moving forward. So last but certainly not least, I want to introduce you to Dr. Carolina Batista. Carolina has been an outstanding advocate for not only NGDI, but for me personally. So I have to thank her so much for all the help and support she's given me over the past few years. Carolina is an outstanding global health leader and expert who's been at the forefront of improving health and access to care for people in various countries for almost over 20 years. She is currently the head of the global health affairs at Bacharach Impact Finance, where she works to bring together data analytics and innovation to catalyze investments in health solutions for the underserved. She's played numerous roles, and I won't go through them all because we'll be here for the next 2 hours because Carolina's had an outstanding and distinguished career. But I do want to mention her work with Doctors Without Borders and with DNDI in particular, as well as the work she's done with the Lancet COVID-19 Commission. So today she's going to talk about a very important aspect, which is the evolving challenges and impact of migration and climate change on neglected diseases. So without further ado, over to you, Carolina.
Thank you so much, Kish, and thank you everyone for staying, for hanging in there, and thank you so much, especially for my previous panelists. I've been very inspired, and it's an honor to wrap up this conversation today. And a lot of the things that you've said will definitely resonate with my presentation. Thank you for the invitation here, and it's really rewarding to see an audience of people from all over the world, including dear colleagues and friends that are joining from my home country, Brazil. As Kish said, my presentation will be an attempt, of course, to basically invite you to delve with me into the intricate web that connects NTDs, neglected diseases, climate, socioeconomic inequalities, and forced migration. So basically, we're not talking about a handful of people. We're talking about neglected diseases as a condition that affects over 1.5 billion people all over the world. It's not a rare condition. And of course, it's a disease that's global. Of course, some countries are more affected than others. But I think what I would like to call our attention here is that out of the world's poorest, over 1.4 billion of these people are at least suffering of at least one of these conditions that are, of course, very closely linked to poverty, exclusion, and vulnerabilities, and we'll go a little bit more into that. So, as I just said, these are diseases that are linked to impoverished populations, people who have chronically suffered from lack of access to healthcare, to dignity, to having their voice heard, and of course they're disproportionately affected by such conditions. I'd like maybe to remind of a beautiful book that if you guys haven't read it, you should, by Peter Hotez, our first speaker who joined us from India, and he wrote many years ago the book called Forgotten People, Forgotten Diseases, and it was exactly about neglected diseases. And as not only Peter, but a lot of us here in this conference today tend to say these are not neglected diseases, but neglected populations that suffer disproportionately from these conditions. Some of I think what's important also to say is that the legacy of colonialism also has left a very hard stain in the distribution of these diseases, where we can see that populations of color, minorities, and indigenous populations are also affected. And as you can see on the picture here, it's a patient I used to treat when I lived in the Amazon as a physician. an indigenous man who lives as a hunter-gatherer who had lost his vision because of trachoma, a neglected disease that it's preventable, it's treatable, but because of the chronic lack of access to care, he became blind. So that's just an example of how that can impact a population or a person like this man who needs to be out there in the forest hunting and providing for his family. So the impact is enormous and very important to try to quantify. Of course, these diseases are very closely linked to poor sanitation and access to clean water. If we think that about 2 billion people around the world don't have access to drinking water, and more than 3.5 billion, more than half of the world population, lack access to adequate sanitation. So that's definitely elements that really enable these diseases to thrive in poverty. So that's a very important aspect to think. Of course, the economic and the socioeconomic impact of neglected diseases cannot be overstated. As we can see here on the map, this is from the latest WHO neglected tropical diseases report. This is the distribution of neglected tropical diseases around the world and the DALYs and the disability life years that are lost because of these conditions. Some of these conditions that are considered neglected tropical diseases, such as dengue, for example, they don't necessarily lead to mortality, but they lead to loss in productivity, absenteeism from work, and of course, they make people incapable of being economically thriving and active. So that's, I think, important to keep in mind that there is an absolutely need to better research and collaboration to quantify the economic losses and how that impacts people to thrive, but also that how that contributes to people being trapped in this vicious cycle of poverty, disease, and neglect. Just to very briefly, we're not going to go into the details here, but of course, one of the main features of neglected diseases also is the market failures, the lack of interest to market. And I think Marianne before me was just making a very compelling case for the need to new ways of ensuring access to technologies, to medical tools, since the very early stages of R&D, of research and development. And this is, I think, a good example of research that has been done by colleagues from both the NGDI and MSF in the past that have shown that despite the fact that there's been some progress in increasing the number of research and development studies and also clinical trials and new technologies developed, including vaccines, treatment, and diagnostic tools for neglected diseases, there's still a long way to go, and the fatal imbalance still remains. Every year, the GFinder report provides a very detailed, very interesting analysis that tracks the annual investment for R&D for neglected diseases. And as we can see here, there was an increase in investment for neglected diseases, for R&D for neglected diseases around 2018, 2019, but then we can see a steady decline. Of course, COVID has had a terrible, devastating impact in the allocation of investments for research and development for R&Ds. But also, I think what's important here when we see the graph is the unequal distribution and inadequate funding for some of these diseases. So not all neglected diseases are born equal. Some of these diseases receive much more attention than others. And I'm bringing the case of Chagas disease here just as an example that received only 4% of total neglected diseases funding in 2018. So there's still a lot of ways to go, and also a lot of need for not only further investments, but also private-public partnerships and other types of collaborations between academia, the governments, but also need to mobilize innovative funding mechanisms to ensure sustainable financing for research and development in these conditions. Bringing up Chagas again, just to say that these diseases, they are spreading all over the world. I think Chagas, it's a big passion of mine, and there are a lot of people here today that have been working on Chagas and doing amazing work. And this disease is going beyond its traditional borders because of people's movements, because of migration. And I think there's this aspect of globalization of neglected diseases, of tropical diseases, and we'll go a little bit more into details about it. But I think what's important here to say is that there are over 6 million infected only with Chagas, and which causes a lot of mortality every year. But unfortunately, because of the clinical conditions of the disease, but also, as Keith reminded us very well in his presentation, the social determinants of health, the social and the political determinants of health that really keep this population in the visibility. So less than 1% of the people estimated to be suffering from Chagas disease have access to diagnose, and of course, less than 1% have access to proper treatment despite being available and not accessible. So now thinking about how the climate is inducing migration and people's movements, but also the nexus of climate, migration, and environmental changes and infectious diseases and the emerging of diseases. So there are recent reports that have been very clear in stating the nexus and the interconnectedness of climate change, environmental degradation, and biodiversity loss, forced migration, people really not being able to sustain their livelihoods, losing their crops, losing their land. And of course, there's some reports that estimate that about 140 million people will be forced to migrate by 2050. So it is very important to keep that in mind. And this 140 million people are expected to migrate because of climate change and environmental degradation that escalates them. Of course, the health risks, only if we look into these pictures, and being from Brazil, I receive updates often from people who have to go to the streets with floods and are exposed to diseases that are vector-borne, but also the impact of the recent droughts throughout the world, and how that escalates and catalyzes more risks for health, for disease, but also for socioeconomic impairment of these conditions. What is the connection between inequalities, socioeconomic inequalities, poverty, migration, and lack of access to healthcare? They're all very, very interconnected, and I think that's a call to action for all of us to, in our own fields of research, of engagement. As Keith reminded us, we have a role to play in providing, in doing the research to do the attribution that we need to do. We need to invest more in social science and qualitative research to understand the drivers for migration, but also the health risks that these people have. So the health risks for migrant populations occur not only before they decide to migrate, which is a very complex decision, of course, but oftentimes these people are people who are already poor, who have no access to care. They already have higher risks for neglected diseases, for infectious diseases, and other conditions. But during the migration journey, a lot of these people also live, as we can see here, in terrible conditions, in places where sanitation is nothing but a dream. And of course, when they arrive in the destination country or context, they also oftentimes are pushed to live in bad conditions, in bad sanitation. And of course, this increases the risks for developing conditions and infectious conditions. So this is just some of the drivers, some of the links between socioeconomic drivers for migrations, climate change, and in Latin America. This is it's going to be published soon. It's part of my research with my group at the Lancet Migration in Latin America. And then we can see that it's all very much interlinked. poverty, inequalities, Latin America being one of the most unequal regions of the world, where the gap between the very poor and the very rich just widens, and COVID has definitely contributed to that. Of course, land degradation, crop losses, and all of that definitely contributes to engaging people into the decision of migrate. I think also what's important to think is, yes, neglected diseases, yes, tropical, not so much. There are a lot of new studies and reports that have demonstrated that the warming temperatures provide a very fertile ground for vector transmitted diseases in parts that were not previously affected by such conditions. As we're here today with Kish and our colleagues from Canada, this is just an example of a modeling exercise that is looking into Canada and how the warming climate and the climate variability will lead to increased epidemics and emergence of infectious diseases in Canada because of the warming in North America, but also because of populations movements. I'd like maybe to call the attention also of the legacy of colonialism and the unequal impact of the climate degradation, land abuse, and grabbing in populations such as the Brazilian indigenous, for example, that have very, very often contributed nothing or very little to any types of climate change and degradation, but they, of course, are very much at risk of suffering the consequences of the climate degradation because of their very close connection and subsistence with the land where they use. So that's definitely something to be thought about. There's this whole concept of climate justice and how we can think of ways to protect and to create resilience with these communities by working with them to co-design solutions that they can be protected and better adapted to respond to the consequences of climate change and environmental degradation in their lands. I love these graphs. I am a graph nerd, and this is an exercise that was done by scientists at Stanford. And so the big graph is what we have now in terms of the vector presence in vector Aedes aegypti vector. That's the mosquito that transmits dengue fever, Zika, yellow fever, and all of that. As a Brazilian, I grew up knowing this name and smelling the fumigation every afternoon when I was growing up with the public health efforts to address the mosquitoes, and that's what we have now. The red parts of the world are the parts of the world where the mosquitoes are the vectors are most present, are most prevalent, and you can see that there's the global north is getting there, but very, very little exposure to the vector in months. So this is the colors are every month of the year. Estimations, modeling exercises, and fast forward to the year 2080. So many years from now, but not many. And then if we keep business as usual, so you can see on the left, on the right graph, if we keep business as usual, if we don't decrease the emission of gas, of CO2, etc. So if we don't change our lifestyles, that's how the world's going to look. So you can see that there will be much more exposure to vectors in many more months throughout the year. So you can see that the global north gets much more exposure to that. However, if we comply to the Paris Agreement and to the other calls to actions that have been put in place more recently, and decrease the emissions of gas, and we collectively act to address the global warming, we can see that there's not much change from what we have, the scenario that we have now. So the time to act is definitely now, but that will take strong partnerships and collaboration between the different actors. This is just a graph. I'm happy to share that with you guys, but I think it's interesting to see how tackling neglected diseases really sits in the interconnection of research, human rights agenda, but also the Sustainable Development Goals. And the Sustainable Development Goals, we were very lucky to have Keith presenting about them and how far we are from achieving the global targets, and how COVID has set us back many, many years, and we have a lot of work to do now. But neglected diseases and addressing neglected diseases really provide us with a good roadmap to achieving Sustainable Development Goals. Not only the Sustainable Development Goal 3, which is the good health and well-being, but also the others. By addressing neglected diseases, you're inevitably addressing poverty and taking people out of that vicious cycle of poverty. You're reducing inequalities. You're really working on climate action by addressing, for example, the land grabbing or the environmental degradation, deforestation that leads to that. So it's very much interconnected, but also the UHC, the Universal Health Coverage Agenda, can be extremely positively impacted by successful programs on neglected diseases. Because if we remember, neglected diseases are affecting the most vulnerable people, the most remote populations in the world. And of course, by addressing the needs of these populations, you can definitely support the achievement of universal health coverage, which very much entails that everyone has access to the health they need without having to endure financial hardship. So there is hope now. There are global goals by the WHO and partners to end neglected diseases, or to control and eliminate neglected diseases in the coming years. There is a roadmap that has been developed, and I think the pillars really provide us with some blueprint to move forward. But no one can do that alone. I think COVID was a stark reminder that showed the health systems underperformance and underinvestments. Health systems everywhere in the world, high-income countries, low-income countries, and low-income countries have been strained to the max to address the impacts of the pandemic. We've seen the lack of resilience of health systems in countries, but of course, the high-income countries have recovered much faster, and the legacy of COVID in low-mid-income countries still needs a lot of effort, a lot of concerted action to address those gaps and unmet needs. Of course, the funding gap to achieve the Sustainable Development Goal 3, the health and well-being for all, got bigger. We went backwards with that, and of course, there is a strong risk of reversing the progress achieved to eliminate and control neglected diseases that had been achieved in the years prior. So how can we leverage all of the success stories and all of the success initiatives that have been put in place prior, but also making use and leveraging the advances that have been achieved with COVID vaccination, of achieving the last mile, of achieving people to use that system and that network of health providers, of healthcare workers, to address the neglected diseases that still affect these populations. So I think the message is clear. The time to address neglected diseases and the link between the climate change, environmental degradation, and forced displacement due to that, and how that interconnects with neglected diseases. The time is now. I think COVID has taught us that no one is safe until everyone is safe. So NTDs are not an exception. We can see now the expansion. Disease have no border. So NTDs and vector control, vector transmitted diseases are on the rise and are expected to increase. and we need to act now. I think the COVID also has taught us that what we do between the interpandemic period is what defines how well we'll be responding when a health crisis happens. So I think that working now in strengthening by developing what has worked well and correcting course of what has not done so well in the past has really the potential to allow us to move forward. I think the objective of this webinar today also is to put a magnifying lenses on equity. And I don't think we can overstate equity, the importance of equity enough. And we have today amazing advocates for health equity as audience. And I think that what we learn also with HIV, and Marianne has brought us some great examples. Keith has told us about the political determinants of health, and equity doesn't happen by accident, right? Equity has to be put in the center of all of health discussions and conversations and health systems conversations. So equity has to be at the core so that nobody is left behind. And that includes NTDs, that includes also climate, that includes the disproportionate impact of the environmental degradation in the poorest and the most vulnerable populations. And of course, global coordination will be key and paramount to advance all of these agendas forwards between government, organizations, private sector, communities. The communities have to be in the center. They know what they need to respond to their needs, and they should be protagonists of that. And I would like to thank you all today, and I would love to honor the memory of two neglected disease champions that have left us not so long ago, and I hope that we can all live to their legacy. And these are Kamran Rafiq and Dr. Maweli, who was the WHO NTD's director. Thank you very much.
So Carolina, outstanding presentation. No, I'm not surprised. Outstanding presentation. And I think what was really important is the connection between climate change and NTDs. I think that's become a big issue. And I think you made a very important point about places in the world where we never saw NTDs progress, all of a sudden popping up. And I think climate change and migration play a role. So outstanding presentation. There are a lot of positive comments in the chat. So thank you very much. So first of all, I want to thank all four speakers for outstanding presentations. I think we covered quite a bit of breadth and depth of different aspects of global health equity and access, and some of the challenges and implementations that we need to all consider and think about moving forward. So a few housekeeping items, and then there are an opportunity. We are kind of a couple of minutes over, but not too badly over. A couple of housekeeping items. We've got a survey in where you registered for this webinar that you're welcome to go ahead and fill out at your convenience. Tell us what you thought about this webinar, and that feedback will help us for future webinars. That's the first point. The second is that we are recording these presentations, and hopefully in the next couple of weeks we'll have those recordings available, which we will post on our NGDI website, our Twitter feed, and I have a pretty active LinkedIn page, so I'll throw it up there as well. And third and final, let me see if there are a few questions in the chat that we can go to here. My apologies for my for my internet connection. It's always spotty with lots of snow. So let's see if there's any. Do I see any questions here that? Okay, just a lot of good comments about very positive talks, very nice talks. People do have to dash to meetings. If there are no questions, what I would also recommend is that you're welcome to send me questions to kishore.wasan@ubc.ca or to our people, and we can certainly send them back around to everybody around as well. I want to first also thank Fahan and Matt. Matt and Fahan work for Richard Lester, and they have done an outstanding job helping internet challenge people like me to make sure that we could run this webinar nice and smoothly. So thank you, Matt and Fahan, for all the work that you've done behind the scenes as well. I want to thank the members of the NGDI Advisory Board. They have been very, very supportive in moving NGDI forward. They're the reason why NGDI exists. And I thank all of you for attending today. I don't see any questions online, but you're more than welcome, as I said, to send questions through to me, which I will send on to the speakers. So if there's not anything else, I think we can close our webinar, and thank everybody for your attendance. And I hope everyone has a wonderful rest of your day, and let's stay connected. I think it's important to keep moving this agenda forward. So thank you very much, everybody.
Thank you, Keish, very much. Thanks,
Thank you.
Caroline. Thanks, Marianne.
Thank you so much,
to see you.
Marianne and Keith. It was really great, and I learned a lot from you. And Richard, let's definitely talk and yeah, think about it.
No, you all raised lots of key points. I almost wish there was more time for discussion. I'm sure there will be a lot of discussion happening as a result of these presentations. So we'll try to ensure we provide some of that feedback back to you all as well.
Thank you.
Thank you, Richard.
Yeah, thank you
So much. Appreciate. Wish everyone a lovely rest of the day. Bye-bye.
Take care. Thanks so much, everybody.
Bye.
Thank you. Bye-bye.